This is a re-recording of the webinar on spinal cord and dorsal root ganglion stimulation, originally presented in January 2019 for the mentorship group. Neurosurgery for pain alleviation can take many forms. In its most basic sense is removing the offending agent, often an anatomical obstruction, such as a microdiscectomy for radiculopathy. Lesional or ablative pain surgery has a long history, although its use declined given the rise of neuromodulation. However, these procedures still have an important role in intractable pain syndromes, such as Dres lesioning for brachial plexus avulsion pain. When we talk about neuromodulation, it can include both intrathecal therapy or neurostimulation. Specifically today, we'll be reviewing the basics of both spinal cord and dorsal root ganglion stimulation. So we all know that the burden of chronic pain is enormous, and it confers a high cost to both the individual and the society. It's actually the most common reason to see a physician and is responsible for a significant proportion of workday absences and lost work capacity. It has a prevalence, an astounding prevalence of almost 30%. Very topical is the burden of pain in relationship to the opioid epidemic, which has had a devastating effect throughout the United States. And neurosurgeons have specifically employed neuromodulation as a way of addressing, at least in a small capacity, the opioid crisis. So when we talk about neuromodulation, the basic theory behind this is the gate control theory of pain. And this is the most famous and well-known physiological theory of pain transmission. It was first proposed by Melzack and Wall in 1965. In very basic terms, activation of nerves which do not transmit pain signals or non-nociceptive fibers, this interferes with signals from pain fibers, thereby inhibiting pain. So both small diameter, or the pain transmitting fibers, and large diameter, or those that transmit touch, pressure, and vibration. These are afferent nerves that carry information from the site of injury to the dorsal horn. So large diameter fibers excites inhibitory interneurons, which ultimately reduces the transmission of cell firing. So therefore, less pain is felt when you have more activity in large diameter fibers compared to that in small diameter fibers. However, this is an incomplete theory when it comes to explaining spinal cord stimulation. It doesn't completely explain the role of pain alleviation in neuropathic and nociceptive pain, and especially for newer therapies such as high-frequency stimulation, which we'll get to in a bit, it is an incomplete theory. So today for this talk, we're going to be talking about both spinal cord stimulation and dorsal root ganglion stimulation, and we'll start with SCS. So when most people think about spinal cord stimulation, they think about low frequency or tonic stimulation, that which produces paresthesias. And so this is dorsal column stimulation, commonly using 40 to 60 hertz, although anything under 100 hertz is typically considered low frequency. The indications for this are primarily failed back surgery syndrome and complex regional pain syndrome. There are expanded indications. Really any neuropathic leg or back pain can be considered an indication for spinal cord stimulation. What this does is it reduces the pain with paresthesias that overlap the painful area. The seminal studies by Kumar and North on spinal cord stimulation originally showed that it was great for neuropathic leg pain. However, back pain was very poorly treated. Some issues with tonic stimulation is that patients can actually develop tolerance to stimulation over time. And this can result in a loss of efficacy. It can be over a number of months or over a number of years. And also paresthesias can become bothersome to patients. And we do know that paresthesias are actually affected by postural changes as well. So the leads in the epidural space in relationship to the thecal sac, how much CSF, and how close they are to the dorsal horn. So that changes with position. And so when we are upright and walking, that's kind of the optimal stimulation. However, when we sit down or when we lay down, that space tends to decrease, and the paresthesias can actually be felt in a more intense manner, and especially for patients who are trying to sleep, this can become bothersome and interfere with their sleep. So SCS placement is done either percutaneously or through an open laminotomy. The use of fluoroscopy is integral to doing either of these techniques. It's always important to realize the level at which you're putting the stimulator. So typically when we talk about conventional targets, that being low back, leg pain, T8 to T11 is very conventional in terms of that. Actually, visualizing these levels is very important. It's important to have a grasp of preoperative imaging and the intraoperative imaging. So patients may have some aberrant anatomy. Um, they may be missing or have a rudimentary thoracic rib, a T12 rib. And it's important to understand that prior to positioning the electrodes. So usually what we do is we tend to count from both the sacrum up as well as identify the last rib. And sometimes that last rib is very difficult to see, especially in obese patients. So very important to have a grasp of the preoperative imaging and the intraoperative imaging and how they might compare. Um, Patients who undergo a trial will have externalized leads, and you can externalize leads for both a percutaneous and a laminotomy approach. And these are externalized off to the left or to the right flank. They're hooked up to an externalized pulse generator. The device representative typically gives the patient a number of programs that cover the painful areas. The patient goes home 5 to 10 days, typically somewhere around a week. And see exactly what programs work for them. And what we want to see is 50% or greater pain reduction in their normal daily pain. And if they achieve that, then they're candidates for internalization of the hardware and placement of the pulse generator. And when you consider placement of the permanent hardware, you have to look at patient body habitus. Usually we tend to implant this in the left or right flank or in the buttocks. It's important to understand where the patient actually wears their belt. You do not want the generator to be on the belt line itself. It's also important to ask the patients if they tend to sleep on one side versus the other, because if they sleep on the same side as the generator, that tends to become uncomfortable. So this is a fairly good slide in terms of gross localization, what we look for. So as I mentioned on the last slide, T8 to T11 is great for back and leg pain. However, you can get trunk coverage anywhere throughout the thoracic spine, and that's usually for something like post-herpetic neuralgia. You can go into the cervical spine for hand, shoulder, neck, or jaw pain. And remember, this is all relationship to the vertebral level. What's very important about this is also lateralization and coverage intraoperatively. So when we're testing in either a trial scenario or permanent implantation, the patient can be either awake or asleep with intraoperative neuromonitoring. And so if a patient has typical pain that radiates from their buttocks down their posterolateral thigh to the dorsum of their foot, you want to make sure that you're getting the majority of those areas with coverage, and the patient can tell you themselves if they're awake during the trial. And so if you're getting the bottom of the foot but not the dorsum, then that's obviously an inadequate coverage. And with your device representative, you're going to be looking to reprogram based on where the contacts are, or you might actually have to reposition the lead itself. Now with asleep neuromonitoring, you also have to have a good team, a good neuromonitoring person, as well as a good device representative. And you're looking for bilateral activation with your EMG recordings. And sometimes what you can actually see is if you're increasing the voltage, you're not getting any activation, or you're suddenly getting it at higher voltages, you might actually be in a true midline position. And if you're getting it with very low voltages, you might actually be ventral. So very important to look at your fluoroscopy, where the midline position is, and doing a lateral view as well to make sure you're in a dorsal position. And of course, remember that anatomical midline does not necessarily mean physiological midline. And so that's important to see from both what you can see in both an awake and an asleep scenario. So a large amount of innovation recently has been in waveform design. So tonic frequency was the mainstay for many years and continues to be so. However, about in the past 5 to 10 years, high frequency stimulation has become a big contender in this field. And so about 5 years ago, a big study on 10,000 hertz frequency was done, and that's versus the normal 40 to 60 hertz. The important part of this is that there's actually no paresthesias involved in high frequency stimulation. 10,000 hertz does not have to be, it's not synonymous with high frequency. It can be anywhere from 1 to 10,000 hertz. Some companies do use 1,000 or 1,200 hertz. There is evidence for better outcomes using higher frequency compared to traditional spinal cord stimulation. The big one, though, is back pain. If we go back to the Kumar and the North studies, back pain was inadequately treated compared to neuropathic leg pain. So the slide I'm going to show you here is from the seminal Senza study. This is the 1-year data showing that 10,000 hertz is superior to tonic stimulation for both neuropathic leg and back pain. And there was a follow-up study done that showed that this was maintained also to 24 months. So this is very exciting in the field because now there was evidence that we were able to treat back pain with spinal cord stimulation, whereas previously it was kind of dismissed in terms of patient selection. So high frequency, as I said, is a lack of paresthesias. So this also allows the patients to use the stimulation throughout the day, including while sleeping and not having the bothersome change in stimulation pattern. There is a potential disadvantage, and that is the increased power consumption. What this usually necessitates is having a rechargeable battery, and they'll need more frequent recharging, sometimes even daily recharging. There have been some studies looking at how much high frequency is necessary, and some have thought that 1,000 versus 5,000 versus 10,000, they all provide the same amount of pain relief, although it's a bit of controversial data. As I've mentioned, though, some companies do use 1,000 or 1,200 hertz as their high frequency stimulation. In terms of mechanism, going back to the gate control theory of pain, this actually does not apply because high frequency stimulation actually does not involve action potential propagation. So you're not activating those inhibitory interneurons. So we actually don't know how high frequency stimulation works. There's been a number of theories proposed, such as desynchronization, temporal summation, stochastic firing. Again, incomplete theories. There's possible inhibition of wide dynamic range dorsal horn neurons. This is still ongoing research. So we're going to switch gears now and go to DRG stimulation. So why DRG stimulation? There's a number of advantages here. First of all, the DRG is in a predictable and accessible location. It's in an epidural space. We know it's in the neural foramen. What's actually very advantageous is that there is limited CSF around the DRG. So as I mentioned before, there is a cushioning effect of having CSF in the thoracic intrathecal space in between the epidural lead and the dorsal column itself. However, having less CSF around the DRG actually has the electrode closer to the anatomical target and allows stimulation with less energy. And also you can have, or you do have separation of the sensory and the motor nerve fibers, which prevents unintentional stimulation. So this is very important in terms of when you're actually implanting it to make sure you're in a dorsal versus a ventral location. And you can see that on lateral fluoroscopy. So where DRG stimulation excels is in the areas we can't typically get with spinal cord stimulation. And those are areas that are more localized to a dermatomal distribution. So when we think about that, that's pelvic pain, groin pain, foot pain, buttock pain, abdominal pain. And this type of stimulation can be used with or without paresthesias. So the big study for DRG stimulation was the ACCURATE study. This was a multi-center study with 22 investigational sites. There were 152 subjects that were randomized to DRG versus conventional commercially available spinal cord stimulation. And this is specifically for CRPS of the lower extremities. The primary outcome is the typical 50% or greater pain relief. And what was shown at 1 year was that DRG was superior to conventional spinal cord stimulation. There was less positional variation, as I mentioned, because of that decreased CSF space, reduced power requirements, and reduced lead migration. So DRG lead placements can be a bit tricky. It is done percutaneously. You are targeting the contralateral pedicle of where you'd like your lead to be. And so typically you choose a level of about 2.5 pedicles below on the opposite side, and you enter an oblique angle. However, you're using the same loss of resistance technique as you would for traditional percutaneous placements. What's different here is also the hardware itself. There's a specialized introducer with a stylet and the electrode. It's important to have a good grasp of this hardware, and there are specialized courses you can go to. You need to have a good relationship with your device rep and, who can be in the room and help you through this technique. What's unique about the DRG lead placement, which allows for the lower migration, are these hairpin strain relief loops. And you can see this on the bottom right here, a loop that's going both superiorly and inferiorly. It can be actually quite difficult to get this. It's not always a textbook perfect, but these strain relief loops do reduce the migration rates quite a bit. What we do at our institution in terms of a trial is we do what we call a permanent trial. So we actually implant the leads and then we externalize extension leads. Because of the difficulty in getting these into proper positioning, we don't want to have to do it twice. And so the patient goes home with their externalized pulse generator, and should they be candidates for implantation, then we just remove the extension leads and implant the actual electrodes into the IPG device. And what's very nice about this is that you can have 4 separate leads into an IPG, so you get bilateral coverage at multiple levels. So the pros for DRG stimulation, as I said, it's a bit of a steeper learning curve. It's important to go to the courses that are offered. There are many excellent instructional videos, but obviously getting hands-on experience is the best way to do this, and just getting practice. Very important is knowing limitations based on patient anatomy, and getting both, I would say, both MRI and CT imaging. Foraminal stenosis is not a contraindication, but can be a roadblock to getting the best coverage. So some hints you can see are the neuroforaminal fats on MRI, which can show that can be more challenging. Patients with advanced degenerative disease, with advanced osteophytes, with scoliosis, it can be very difficult to get these leads into the proper position. And actually, because of the limited space, if you're trying to advance these, you can actually cause a pretty profound radiculopathy. So very important to, when considering a patient for a trial, to get the appropriate imaging and examine it quite closely to be sure that these are appropriate candidates. So in summary for this talk, some take-home points. Pain surgery, especially neuromodulation, is done in a multidisciplinary setting. It's very important to get patients down to at least 90 morphine equivalents before implanting. It has been shown that patients who are opioid dependent or have higher opioid doses are more likely to fail spinal stimulation. As I mentioned, that multidisciplinary setting, we need to see who is managing the patient's medications. That can be their pain specialist, a neurologist, anesthesiologist, or their primary care physician, and to talk with them and make sure that the pharmacotherapy reduction is taking place, and looking for other adjunct non-narcotic medications. When you see a patient in consultation, you don't want to necessarily say that you're going to be doing spinal stimulation or dorsal column stimulation in your consultation note. The reason being is that basically excludes dorsal ganglion stimulation. So when you see a patient who you believe may be appropriate for either therapy, you do want to say spinal stimulation, because that can include both DRG and SCS and allows some flexibility. And in the end, patient selection is key. You need to have a motivated patient, someone who's not on heavy doses of narcotics. They have to go through pain psychology. What we do at our institution is get urine opioid screening. Obviously, if there's some type of anatomical obstruction, that's what's removed first before proceeding with stimulation. There has to be an externalized trial period, usually about a week. We want to see patients who get 50% or greater pain relief. And then once all these factors are addressed, then we proceed with the internalization. Thank you for your time.